Good morning, everyone. Welcome to our final talk in our Global Symposium series today with movement disorder specialist Dr. Antonio Strafella, speaking for us today on personality and behavior changes in Parkinson's. My name is Alana Dillon. I'm an Education and Support Services Coordinator at Parkinson's Society BC, and I'll be facilitating our webinar today. Before I introduce Dr. Strafella, I'd like to go through a few housekeeping items. First, I want to let you know that we are recording this webinar, so it will be posted on our website. Secondly, you will see a chat icon at the bottom of your screen. If you click on that icon to open it up, you may use that chat box during the webinar to make any comments or questions on today's presentation topic. And Dr. Strafella will answer those questions at the end of his presentation. And you may also use the raise hand function to verbally ask a question. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume both on your computer as well as on your actual speaker so that you can hear the webinar well. It's my pleasure to now introduce internationally recognized movement disorder specialist, Dr. Antonio Strafella. Dr. Strafella is a professor in the Department of Medicine, Division of Neurology, and the Krembil-Rossy Chair in Molecular Imaging of Neurodegenerative Diseases. He is a movement disorder neurologist in the Edmond Sara program in Parkinson's Disease and Morton and Gloria Shulman Movement Disorders Clinic at the Toronto Western Hospital. Dr. Strafella is the chair of research for the Division of Neurology, Department of Medicine, University of Toronto, and a senior scientist at the Krembil Brain Institute and at the Brain Health Imaging Center at the Center of Addiction Mental Health. On the national front, Dr. Strafella is a fellow of the Canadian Academy of Health Sciences and currently serves on its governance and finance board. He also serves on the advisory board of the Canadian Institutes of Health Research, Institute of Neuroscience, Mental Health and Addiction, and the board of directors for Parkinson Canada. Internationally, Dr. Strafella is involved in several other commitments with the International Parkinson and Movement Disorder Society and World Federation of Neurology. The focus of his research is on Parkinson's disease and atypical Parkinsonism using advanced neuroimaging technology. Dr. Strafella, welcome, and thank you for being here today to speak on personality and behavior changes. I'll pass it over to you now. And it looks like we lost Dr. Strafella. He was here, but let me see what happened. Oh, there he is. He's back.
Sorry, I think can you hear me?
I can hear you, no problem.
Yeah, sorry, I think it was the internet went down. There we go. I'm going to share again. Can you see it?
Yeah, looks great. I
Perfect.
can see it.
Okay, so thank you first for inviting me, and of course, it is a pleasure for me to be here as the last speaker of this series, and I hope that the internet connection will be stable throughout my presentation. So hopefully there won't be any disconnection. So I'm hoping that everybody can hear me well, and so if it's yes, I will continue with my presentation. So, of course, I'm assuming that everybody on this Zoom meeting has some kind of a connection with Parkinson's disease. And let me start to say that Parkinson's disease, you probably would agree with me, is a great unknown disease. So we know, I have to say very little about this disease, and probably the best representation is like the tip of the iceberg. And there is quite, let's say, part of the disease that is completely unknown to us at the moment. And we are learning over the years that things are quite different than what we thought in the first place. And generally, many colleagues work in the field would agree that what we consider Parkinson's disease 10 years ago is now much different today. So Parkinson, of course, is quite well represented in Canada and in the rest of the world. And of course, across the different provinces, we have a very large representation of this disease among male and females. And of course, we know very well that this is a disease that becomes more prevalent with aging, and the majority, of course, of our patients are always in the range of 55 and above. And again, some of them are still working, very active in the society, and others are retired. So we know that this disease has a significant impact on the family and on society for, of course, a number of reasons. And so, as I always say, also with my patients, when we discuss these issues, it's not just a diagnosis for the patient, but it's also a diagnosis for the family, because a significant part across the different members of the family. So this is the current status in Canada with a different percentage, but again, this applies very well to the US, Europe, and any other parts of the world. So let me start first to introduce Parkinson, but I'm pretty sure everybody here in this call and each one of you are very much familiar with the different symptoms of Parkinson's disease. So, of course, by definition, we define Parkinson as a movement disorder, because the first time that patients come to the clinic is because they start experiencing tremor, they start experiencing some rigidity, stiffness, slowness of movement, of course, and they always mentions that their posture becoming more stooped, and many other features, of course. But over the years, we learned that Parkinson is not just characterized by motor features. There are significant non-motor features. And again, each one of you here are very much familiar. I will talk throughout the presentation of cognitive behavioral changes that patients experience. But again, we know that all patients may experience, of course, also what we call orthostatic hypotension. They feel dizzy when they stand. They may have a significant constipation or urinary dysfunction. So these are non-motor features that are very, very common in all the patients. They also tend to report sleep disorders of different kind, sometimes also pain at different joints. But again, this for us is becoming not just a movement disorder, but a disorder that is associated with non-motor features as well. And so when it comes to mechanisms or what is responsible for Parkinson, here is definitely that part of the iceberg that we don't know yet. We know that most of the cases are unknown. We call idiopathic Parkinson disease. Very small percentage of patients, they may have some kind of genetic predispositions, but again, is a minority. We know that the environment sometimes can play a certain role, but again, also in this case, is a small minority of patients. And for sure, there is an interaction between genes and environment that we're not really aware of, but it's probably very likely to play a significant role in this disease. And I would like to show you this slide, because I think it gives you a sense of the progression of the disease over the years. And I would like to probably start focusing mostly on what we call prodromal Parkinson disease, that which is even before the motor symptoms start. So before the patient start experiencing motor symptoms, most of the time, most of the majority, if not many patients, start experiencing what we define as REM sleep behavioral disorders. So probably you or your partner are familiar that during nighttime, during the stage of dreaming, you start acting out in your dreams, like punching or kicking with your legs, or talking, speaking in your dream. So this acting out is called REM sleep behavioral disorders, and sometimes can be seen in our patients many years before the symptoms, the motor symptoms starts. So this is something that now we are aware of, but not necessarily all the subjects that experience these REM sleep behavioral disorders eventually will develop Parkinson, but a good majority, a good percentage, they will. And among other symptoms that can precede the motor aspects can be generally sometimes anxiety, depression. Another feature is the lack of sense of smell, hyposmia, and also severe constipation could be another feature. But again, this does not apply to every patient, but let's say as I always say, every patient is different. But many patients may complain of this prodromal stage where there is a REM sleep behavioral disorder, constipation, depression, anxiety, hyposmia. And then, of course, once we have the diagnosis of Parkinson with all the classical motor features that are bradykinesia, rigidity, tremor, so all this becomes early stage Parkinson's disease. And then here we have what it becomes very common sometimes in patients. They start experiencing fatigue, feeling tired, lack of energy. Patients, of course, may have also these changes with their cognition or behavior, and apathy can be, or lack of interest can be another feature. And of course, also some occasionally, but not very common, pain as well. Then we have the middle stage of Parkinson's disease, where the motor features become more prominent, and that's we call motor fluctuations. But again, then with a variety of different experience among patients, you will have patients that they say they experience more hypotension in the sense of feeling dizzy when they stand up, or they have urinary urgencies, urinary symptoms, and sometimes they may have, of course, visual hallucinations, and that's transitioning towards the late stage of Parkinson, where also significant cognitive decline is might be observed with dementia, and plus other behavioral complications. So this is what is the classical evolution that we see more or less in every patient, with plus and minuses. Again, remember, every patient is different, and the progression of the disease can be different among patients. Not everybody behaves in the same way. So from a mechanistic point of view, I should probably remind that generally what we consider Parkinson's disease at least 10 years ago was this lack of dopamine in the brain. And we know that this substance, this chemical in the brain that is called dopamine, is very important because it innervates different parts of the brain. But most importantly, we know that dopamine plays a role not just in motor features, but also in a number of cognitive functions, like what we call short-term memory executive functions in learning. And also another feature that I will mention after is the reward, which is associated with certain complications that we have in a certain percentage of patients. It's called impulse control disorders. I will mention this late in the presentation. So, of course, every time I have a patient coming to the clinic, start experiencing some changes in behavior, some changes in their usual let's say, way they used to deal with things, then my first concern is what we call mild cognitive impairment. So mild cognitive impairment, or MCI, is a feature that is very, let's say, uh, uh, common, even though here in this slide you can see that up to 60% of patients sometimes do not have any cognitive problems. About 20%, or probably even more, they experience this MCI, this mild cognitive impairment. And when I mention MCI, is mostly what each one of you, when they go to the clinic, they start mentioning their short-term memory. Short-term memory in the sense that they start planning things during the day and they forget unless they write it down, or they forget. They tend to forget also what they have done yesterday or just in the morning, for example. So it's mostly in relation to short-term memory. And sorry. Sorry. And the majority of patients always, they report in the clinic, they tend to remember extremely well what they've done in the past, many years ago, but they tend to forget what they have done yesterday or just during the day. So this is what we call indeed mild cognitive impairment. And as a very small percentage, about 17%, they might develop also dementia, so a more, let's say, significant cognitive decline. And again, there is no a way to really predict who is going to evolve in that towards dementia and who is not going to evolve over dementia. So is you have, I mean, every patient again is different, they behave differently, and you have to. The only way is just to follow the patient over time and see how each one of you or each patient does during the years. So the next slide is just for you to get a sense of what we do in research, for example, to try to investigate these cognitive decline, in the sense that patients, of course, may experience changes not just in the dopaminergic system, which is the reason why, remember, we give you a prescription of levocarb, levodopa, Sinemet, which is dealing with dopamine. But when, for example, these behavioral changes start occurring, then we know that also another substance or chemical in the brain is starting to get affected, like the cholinergic system. And we have also another protein in the brain that sometimes tends to deposit and accumulate. It's called amyloid, which can affect cognition and behavior. And sometimes we can see changes also in the MRI, but even though most of the time changes are very subtle, they do not show major or significant changes. And one of the most challenging complications that we have to deal with during the course of the disease is, for example, of course, depression, apathy. Patient becomes very much apathic to things, like lack of interest to many things that we're engaging before. Anxiety can be a major challenge. Hallucinations, among the psychosis, visual hallucinations are the most frequent among patients, and a small percentage of patients they might experience what we call impulse control disorders. So and this I will mention more in detail in the next slides. So each symptoms that we observe in our patients, whether it's depression, anxiety, or apathy, so they are associated with different parts of the brain. And we know that the changes that are occurring in the brain, whether it is dopamine, acetylcholine, or serotonin, they all affect different parts of the brain, and that those are responsible for the depression, for the anxiety, and for the apathy. And these are just I put these for your own interest, to see how the different parts of the brain are responsible for these three symptoms that are quite frequent in our patients. So this, for example, just to give you how complex and complicated things are, even apathy, like this lack of interest, can have a different forms. Like sometimes we have a apathy that we call emotional affective apathy, in the sense that the patient really, there is lack of emotional involvement or affective involvement, and just because that part of the brain, which is here the orbitofrontal cortex, is more affected. But then we have a form of apathy that is more associated with the cognitive part, with the memory, with the the executive function, and this is because this part of the brain is more involved. So every of course is always very complex as a symptom, as the symptom tend to present and evolve during the course of the disease. But we know that when this phenomenology is present, we know that different parts of the brain have become more and more involved during the disease. And again, we know that depression is another challenging complication that our patients tend to experience, and we know that this chemical in the brain is called serotonin. I highlighted here in red, is very much affected. And here I just show you this cartoon where serotonin is basically all over the brain, and so we know that when these changes start occurring with Parkinson, we know that these different parts of the brain are affected. So it is a very, let's say, challenging even for us that we study this disease on a regular basis to really grasp sometimes how complicated and complex is disease, and has become over the years, or at least so different from what we defined Parkinson's disease just 10 or 15 years ago. And visual hallucinations are very much an index or a symptom for us that things are getting more complex with the disease, is getting more advanced. And we know that patients that start describing these visual hallucinations, which sometimes are not frightening. Let's say most of the patients describe seeing animals. Sometimes they see people that they haven't seen in a long time, or they passed away. And so these visual hallucinations, of course, can be during the day, but the majority of the time they say, oh, I just have a vivid dreams at night that they feel like hallucinations. And we know that when these complications are present, these are the changes that occur in the brain, in this part of the brain, which is what we call the parietal occipital temporal region, is where all the visual input are organized and become very much abnormal in patients with experiencing visual hallucinations. So it is something that we are very much aware of, and we know that visual hallucinations is something that is telling us that things are changing in terms of progression of the disease. And this is another important phenomena that I would like to describe, because probably some of you had experienced this in the past or during the years. So we call impulse control disorders, or PANDing, or dopamine dysregulation syndrome. So impulse control disorders, generally they manifest in about 16%, 17% of the patients in response to dopaminergic medications called dopamine agonists. And we know that when they tend to manifest, as a pathological gambling, for example, hypersexual behavior, impulsive shopping, or also impulsive eating, binge eating. And these are the majority, but there are also other minor forms of impulse control disorders that can be present. But these are the ones that patients tend to describe the most. And we have also another group of patients that manifest with PANDing. So this PANDing is a specific behavioral disorder with stereotyped activities, in the sense they certain patients, they keep repeating certain movements or behaviors over and over again throughout the day. And this is also very disruptive when you have these behaviors. And another one that it's very challenging is what we call dopamine dysregulation syndrome. So dopamine dysregulation syndrome is when we have this uncontrolled dopaminergic use of medication. So that unfortunately, a small percentage, a small group of patients that have a very difficult time in controlling the amount of medication to be taken. So they do not follow any prescription or any, let's say, guideline or suggestion. They just keep taking medication with no without respecting any, let's say, prescription that is given to them. And generally they tend to run out of medication very quickly because they tend to overdose over time, and this overdosing is going to lead to other complications. So these behavioral problems, impulse control disorders, panding, dopamine dysregulation syndrome, are neuropsychiatric complications. And sometimes when we have to deal with this type of problems, it's not an easy thing, because implies reducing the amount of medication, and by reducing, of course, the amount of medication, this will lead to more freezing, more bradykinesia, more tremor, more rigidity. So it's very difficult to find the right balance in this case. And again, the reason why all this is happening is because, again, the dopamine is involved in this part of mechanism. It's called the reward mechanism. And we know that there is a small part of the brain, it's called the nucleus accumbens, that is controlling this behavior. And again, it's very challenging for the neurologist, the psychiatrist, to deal with these aspects when they occur. And here is just a slide to show you how frequent these impulse control disorders are. Generally, we see this phenomenology of symptoms more in the younger group of patients. Then it seems to be associated with dopamine agonists like pramipexole, ropinirole, compared to levodopa, for example. Some colleagues also tried to see if there was another factor, like if the patients are married or not married. And it seems to be that maybe if you are not married, there is a higher chance that you will fall into these behaviors. And also, of course, if there is a family history of gambling. So if there is some kind of history in the family or personal history, that will increase the percentage of having these behaviors. So certainly all these are the things that we have observed in the past. I have to say that now that we are more aware of this problem, of course, we tend to prescribe less and less these dopamine agonists, even though we still use them, but we are very more aware and also much more careful in trying to see the first signals, to identify the first signals of impulse control disorders. And this is just to give you a sense of how difficult it can be to deal with these behavioral problems, complications, because again, we have two sides of the spectrum. So if we move towards one part of the spectrum in relation to dopamine level, we might have these impulse control disorders, compulsive use of medication, and panding. But then in the moment we start reducing the amount of medication, we go on the other side of the spectrum, patients of course fall into depression, apathy, having more rigidity, bradykinesia, a tremor. So I have to say, to reach a balance here is very difficult, because each direction we go, there is some kind of price to pay. And so this is one of our challenge. Indeed, now we are aware that every time we try to reduce the amount of medication to control for these impulse control disorders, and pending and dopamine dysregulation syndrome. Then we have this withdrawal syndrome in Parkinson's disease, where the patients start having the significant depression, apathy, and of course significant motor symptoms. And over the years, of course, I had also many patients that they did not want to reduce or stop certain medication because of course, they are afraid of the bradykinesia, the rigidity, the depression, the apathy, and they do prefer more to have this behavior. So it's always very challenging to find a balance, a solution when we have to deal with these situations. And the reason why, and I always like to show a slide why all this is happening, is because, of course, our brain is wired, made to have a certain behaviors, and we know that in Parkinson's disease, but not just in Parkinson's disease, also in other conditions, we have a dysregulation of these important centers of the brain that deal with behavior. Okay, so of course, this is just a slide for you to get a sense of why all this is happening, but the simple reason is just because these parts of the brain that deal with this behavior are getting affected by the progression of disease and the medication, and of course this interaction can be responsible in predisposed patients to develop these behaviors. And again, there is not a magic solution to these problems in general. We have to deal with what we have. Like say, pharmacological approach is always the majority of cases in terms of how we deal with Parkinson's disease, and a small percentage of patients having Parkinson more advanced stages with motor fluctuations, they go into surgical programs for deep brain stimulation. There is not much. I have sometimes patients ask me if there is anything in the field of stem cells research, and of course there is a lot of research in that direction, but at the moment it's pure experimental, and I haven't seen major shift in that direction at the moment. And of course, how we deal with these non-motor symptoms is always very, very challenging for us. You are very much well aware that dopamine, levodopa, Sinemet is probably the most prescribed medication for Parkinson and Parkinsonisms. Dopamine agonists, again, Mirapex, Ropinirole, these are medications that are also prescribed among patients in different dosages. Both most of the time they are combined together with levodopa to give some, provide some support in terms of motor performance to the patients. And of course, we have also COMT inhibitors. You probably know this as entacapone. Is a medication that most of you sometimes take. This is rasagiline or selegiline is another group of medication that sometimes we prescribe. Anticholinergics used to be very much prescribed in the past, and sometimes we still provide this anticholinergic, but not very much to date. And the amantadine is something that we use mostly in controlling dyskinesias. So these are the pharmacological approaches that every neurologist or movement disorder neurologist tend to use across Canada. And of course, we always have to, when we deal with Parkinson, which is a neurodegenerative condition, we always have to think in the long term and not in the short term, because sometimes we have a patient coming to us in the early 50s, and we have to think that these patients has to deal with different kinds of medications over the next couple decades. So, we know that these mix of pharmaceutical compounds needs to be considered over time. We have to think about comorbidities if the patient has also other medical conditions that makes things more complicated, and patient's lifestyle, and of course cost of medication sometimes is also an important factor to consider. When we deal with more senior patients, of course, the likelihood to have comorbidities is much higher. So, and of course, if you have other problems like diabetes, blood pressure problems, heart problems, or any other kind of medical conditions, makes things more complicated in terms of how to combine things, because of course in that case, the response to medication can be less than other conditions, and also if your patients sometimes are in pain because you have back problems, the symptoms of Parkinson are increased, enhanced, the tremor becomes worse, and not necessarily because the Parkinson is getting worse, but because, of course, the tremor, the pain coming from the back is influencing the symptoms of Parkinson. And we also have to avoid certain medication that provide more sedation, because Parkinson per se is already a condition where patients have fatigue, lack of energy, and so they fall asleep, for example, during the day, taking frequent naps. And of course, the medication tend to favor also this aspect. And so we have to keep that in mind, especially if the patients are still active, driving and so on. So these are all things that need to be monitored over time. In terms of non-pharmacological treatment, of course, I mentioned before the deep brain stimulation for surgical approach for Parkinson, but again, that is not the majority of our patients having that intervention. We need to also think about sometimes physical therapy. The physiotherapy can help, or any type of exercise sometimes is very useful for our patients. Occupational therapy is something that we tend to involve in order to make things easier around the house. Speech and language therapy, especially for patients having significant problem with their speech. Hypophonia is mostly slur speech are the most challenging aspect. Sometimes also we suggest to see a dietitian to balance their diet, and of course psychosocial intervention when the problem associated with this behavioral complication, especially impulse control disorder, is very much important, this intervention. Again, the reason why, because of course it's very difficult to deal with hypersexual behavior sometimes, or gambling, or binge eating, or compulsive shopping. Those are things that patients sometimes do not like to disclose. And then in that case, a psychosocial intervention can be useful in terms of how to deal and handle this kind of problems. And again, all of you here are very much familiar with the different challenges that we have or we have to deal with during the course of the disease. Again, we know that this disease works as a whole, so it's not that one problem is separated to the other. We know that patients that are having a balance problem, they have a posture instability, gait problem, or mobility problem, they will eventually become more affected also with their behavior cognition. So because it's all interconnected, all the things interconnected in the brain. And so we know that things that tend to develop in terms of gait difficulties, balance, falling, will be associated sooner or later with significant cognitive changes and behavioral changes. So hypophonia is definitely one of the most challenging aspects, or dysphagia, like the swallowing problems. And again, that's an indication the disease is progressing. And of course, having this dysuria, or significant amount of saliva, drooling, is another challenging aspect. Sleep disturbances, many patients, of course, have insomnia, and again, it's difficult to find a good medication to control these sleep problems. And autonomic dysfunction, mostly the constipation, is the most challenging, I have to say, because there are certain medications that could help, but many others do not. And pain is there, but it's probably something that is not very common, at least among my patients. But I'm aware that it can be a problem sometimes. And depression is another feature that can be very difficult to handle. Depression can be the result of many reasons, can be just a response to the disease, and let's say a reaction to the disease, or can be a natural symptom of the disease itself. So in that case, always having the psychiatrist involved in this management is very important, because sometimes response to depression, to this response to medication for this symptom becomes very, very challenging. And physical therapy, I have many patients that they always like to do physical therapies because they feel better, their behavior improves, they feel more engaged. And so I always, if they can, of course, engage in physical activities, of course, walking, swimming, dancing, going to the gym in general, all those things are very important, because it's important. The social interaction is important, also the physical activities. So stretching and, of course, strengthening their muscle is very important for the fatigue. And sometimes I have a patient that, of course, they need some mobility aids with adaptive footwear, and so, because of course, I mean, things can be very difficult for sometimes. Remembering that this is a disease that manifests more and more with aging, and so there might be other problems associated with aging as well. So occupational therapy is something that we like to engage at a certain stage, because of course we need to provide some guidance also to how to modify the home, the workplace, in order to help the patients to deal with all different kind of situations that manifest during the years. Adaptive equipments, of course. Sometimes I always suggest that patients living on different levels in a house, different levels, is not ideal when the disease progressed to a certain stage. And a number of my patients also tend to move on one floor apartment, because that makes things easier if it's possible. Of course, not always an option, but that is something that sometimes they consider as well. And I think I'm getting close to my slides. I mentioned before the dietary recommendations. Again, it's very important, the balanced diet. And again, I always involve a dietitian in this case, because they can provide better feedback in terms of calories to maintain weight, because losing weight is another features that patients that have behavioral complications they tend to experience. Of course, having fibers and fluid to avoid constipation is the minimum that we suggest. And besides, of course, taking stool softeners, and then vitamin D, calcium to deal with the osteoporosis that is a factor of aging, and so not directly associated with Parkinson, but it's something that makes things more complex and complicated for patients with Parkinson's disease. So definitely when I now introduce Parkinson's disease, I have to say that Parkinson's disease is a disease that involves all different parts of the brain, all different chemicals in the brain, and is associated, of course, motor symptoms, even though we call movement disorders, but can be misleading, because patients tend to experience all kinds of non-motor features. And we know now that, of course, patients have all these problems associated with hypotension, blood pressure going down because of disease and medication. So they feel dizzy sometimes, constipation and bladder problems, because of course the changes occurring in the bowel and the bladder. So all these things are telling us that Parkinson is very much more complicated than what we thought in the beginning. So, and now, even when I deal with my patients, I always consider Parkinsonisms more like a big umbrella, because there are many syndromes involved in Parkinson in general. So it's things are changing. Also, eventually, we were going to get also better therapies and treatments in the future. But again, is still a work in progress, and the field is evolving. So I think this is my last slide, and I'm happy now to answer some questions. And I see that there are probably a few in the chat, and thank you for joining. I hope that was useful, at least to get this this presentation, because at least you can provide some clarifications on Parkinson as a whole, and how complicated Parkinson actually is. Thank you. We'll stop sharing, okay? And I'm gonna go in the chat because I see a number of questions, and let's hope I can answer some of them. And yes, okay, I have here the first question is that are back problems related to Parkinson? Okay, so back problems, actually this goes back to one of my last slides, osteoporosis, right? So not necessarily back problems are part of Parkinson, but let's say that if you have a back problem, because many people that do not have a Parkinson have back problems, right? You can have osteoporosis, you can have arthritis that are independent of Parkinson, but those things can make Parkinson worse, in the sense that if you have a back problem with pain, you will feel more the symptoms. Then you will have more tremor, you will feel more the slowness, you will feel more tired. And so definitely if you have back problems, that will contribute to your symptoms, but it's not directly linked to Parkinson. So the next questions is, I'm 84 years old, diagnosed 3 years ago. My symptoms are mild. At 84, what are my prospects? Very good question. I mean, I have to say, if your symptoms are mild, and of course, probably taking a very small amount of medication, if any, maybe probably none. So, I mean, I think at the moment you have to just, your neurologist has to just follow, observe. But again, if symptoms are mild, I don't think you have to, I mean, the symptoms are concerning at the moment. So again, this is a disease that progresses over the years, but progression can be sometimes very slow, and it's very difficult to predict how slow can be for each patient. And let's see, the next question is, can you say more about pramipexole, specifically how it affects emotions? Yes, of course. Now, pramipexole is a dopamine agonist. And again, I mentioned that pramipexole can be very much involved in this impulse control disorders, of course, panding sometimes, not much dopamine dysregulation syndrome. That's mostly in relation to levodopa. And certainly is about a percentage of patients may experience also other behavioral complications. All dopamine agonists, because of influence dopamine, they can have an effect on the mood as well. We know that sometimes a small amount of dopamine is given also to control depression. So, for that reason, we know that plays a role in behavioral complications in general. But again, there is a huge variability in terms of response, and again, sometimes helps, sometimes it doesn't, and sometimes can trigger significant behavioral complications. So again, every patient is different. It is not always easy to predict how one patient will do on one medication. The only way is to start the medication and see the response over time. And the next question is, I'm the care partner of my husband who has early stage Parkinson. I'm having trouble knowing how to define my role as a care partner. Any guidance would be helpful. Okay, of course, here is a very important question, because as I mentioned at the beginning of the beginning of my presentation, this is a diagnosis that affects the family, not just the patient. And of course, caring for a family member is not an easy task. Can be probably easy in the early stage of the disease, but as the disease progresses over time, things become more challenging for the entire family. And that is the why what we do is, as the things become more complicated over the years, we tend to engage also occupational therapies or other supports. For example, here in Ontario, we have what we call the CACC, the community care, where we submit an application. We ask for the manager of the local CACC to speak with the family to see what kind of help is needed, like physiotherapy, occupational therapy, PSW support. And so this, I don't know, of course, in British Columbia, how things are structured, but this is something that can be available uh, uh, when the disease becomes more advanced, at least in Ontario. So maybe that would be a good idea to speak with your neurologist, movement disorder neurologist, what kind of support is possible in British Columbia for the family. So there is research regarding the next question. There is research regarding using mindfulness program for depression, anxiety. Is there any application to patients with Parkinson? Does this help for? Yes, but definitely there is a shift in the field for these kind of programs. I agree with you that it's been applied mostly in different psychiatric conditions, and now I've seen also an interest in our field of movement disorders. Definitely, I think there is probably an application, but really depends on how available is in British Columbia. So here in Ontario, we know that certain psychiatrists or people working in this field have an interest in developing this aspect, but now it is something evolving, an evolving field. So I'm pretty sure will become more and more available in the years to come. But again, I'm not sure how much available is there over there in British Columbia. Here in Ontario is becoming more and more frequent, and there is a possible use of this approach for anxiety and depression. Yes. Is there such a thing as a Parkinson personality? Okay, that's an interesting question. I would say that considering that not every patient tend to develop behavioral problems, but we know that Parkinson has a number of features that are common across patients. So if personality, you intend behavioral complications, I mean, not necessarily that applies to everybody, but as a whole, in the sense that Parkinson has certain features that tend to progress over time and become more or less prominent in certain patients over the others. Yes, of course, then Parkinson's disease has its own personality, but personality in terms of behavioral aspects from the patient, then I'm not sure I would be able to say yes to that question. So thank you very much. And can we slow the cognitive decline, especially memory problem? That is probably one of the most frequent questions I always get with my patients. The only, we don't have a medication to slow down the cognitive decline. The only thing I always suggest, again, is to engage not just in physical activities, but also behavioral activities, to be engaged in many things, because that is a stimulation for the brain. Remember, the brain is a very plastic structure, organ, in the sense that always adapt to different situations. And I always say engaging in physical and mental activities will stimulate your brain as much as possible to challenge the symptoms. So that is the only thing we can do in order to fight the disease, but there is no medication that will help to stop the problem. And thank you. And is there some new time release Parkinson medication that have a good result? Is regular medication assessment with communication between doctor and specialist important? Again, the time release, as you probably know that, of course, we have the slow release medication. Now, time release Parkinson medication, there is a new formulation probably that is available in the US, which is not available in Canada. And I'm not sure, based on my conversation with my colleagues from the US, I would say that is significantly different, even though we never use it in Canada, so I don't have any experience with that. But certainly I heard that there is this time release medication in the US that is available, but whether it's a good or if it's useful or not, I'm not I'm not able to give you an answer. But definitely communication with doctor, between doctor and specialist is important. You mean between family doctor and the specialist? Yes, of course. I mean, it's always important for the family doctor to communicate sometimes with the movement disorder specialist if they have specific questions, because that's something that we always suggest and advise. Can you correct PD posture? Now, this is something very challenging. Unfortunately, PD posture is when you say stoop posture, leaning forward, there is nothing that can be done in terms of medications, in terms of pharmacology. In the past, I would say some orthopedic surgeon tried to do some intervention to that, but I have to say there have been very few cases of surgical intervention from an orthopedic point of view, and things were not did not lead to a good outcome. And so I don't think there's been a great success in that direction. Of course, many patients tend to use poles or in order to straighten their posture, and sometimes physiotherapy. I suggest physiotherapy to see if something can be done to make the muscles in your spine a bit stronger, but again, not a very good solution at the moment. Will DBS improve some non-motor symptoms like insomnia? No, unfortunately not. DBS does not improve insomnia. DBS improves generally motor symptoms, and we know that the symptoms that best respond to DBS are the ones that used to respond to levodopa. So if at the beginning of the disease there was a good response to levodopa from a number of motor symptoms, DBS will have that effect, but DBS does not improve other symptoms that are, let's say, non-motor symptoms. So that's one of the limitations of deep brain stimulation. Do men and women respond differently to PD medication? That's an interesting question. I don't think, I mean, of course, I would say with my current knowledge, I probably would say no, but I'm not sure if that is the correct answer at the moment, because I don't think there are many studies out there comparing the response to medication to men and women directly. So from anecdotally, from my experience in the clinic, I've never heard the huge differences from men and women in terms of response to medication, but maybe I have to say, I'm not sure if that is the correct answer, because there are not really many studies out there comparing the response to medication from men and women in a large scale to give us the correct answer. So that can be still an open question. What level of CNMET frequency would you consider excessive? My neurologist has recommended to take half pill as needed. Now, again, this is something very specific in the sense that in my own experience, every patient has always a different threshold for levodopa, CNMET. In terms, I have patients that with a very small dosage, they tend to develop dyskinesias, and I have patients that are large amount of CNMET and they don't have any dyskinesias. So the threshold is very much different. So of course, if your neurologist thinks that you can add extra half pills here and there, which sometimes I suggest also to my patients, then of course that is based on his own experience, based also because he knows you very well in terms of symptoms and progression. So, but again, there is no way that you can generalize the frequency and the level of amount of CNMET from among patients, because every patient is extremely different. Can dysphagia be prevented? No, unfortunately not. Dysphagia is part of the symptom that we see in all our patients, which sometimes, I mean, not, let's say that dysphagia do not happen to everybody, but when, I mean, it can happen and it's part of the disease. And so it is something that it's difficult to predict in terms of severity when that happened, but again, unfortunately, it's not something that can be prevented. Does Aricept and Exelon help cognitive decline? So let's say that Aricept and Exelon may help the symptoms, the cognitive symptoms, even though in my experience, the response is not great. But so I have a number of patients that they feel that Aricept and Exelon are helping with their cognitive symptoms, but does not help with the cognitive decline over time. So the decline will continue because that is part of the disease progress, but Aricept and Exelon can help a bit the cognitive symptoms, like Sinemet helps a bit the motor symptoms. And I don't seem to smile anymore, and whatever my mood, and how does Parkinson affect that? Yes. So again, this is because of a number of patients have this problem with depression, apathy, lack of interest, and of course their mood is most of the time down, and definitely it is very frequent. Not necessarily this happens to every patient, but it can be there, and sometimes also difficult, because most of the patients that are more sometimes depressed, apathic, they do less exercise, they engage less, and that has all kind of later effect on the disease as a whole as well. Can you comment on the Dodopa pump therapy? Yes, of course. I mean, Dodopa pump is not something that we do in every patient, but is an option available in advanced stage of the disease. Is of course an advanced form of treatment, like DBS, for example. And generally, what if we have a patient that cannot go for Dodopa, for deep brain stimulation, we also consider the option of Dodopa pump, especially because that can help with the wearing off and the motor fluctuations. So it is an option. It's possible, not good for every patient, but it is a challenging intervention, because, as you know, you have to insert this tube in the duodenum, and so that's the challenging part with the pump to deliver the medication. So again, it's an advanced form of treatment that we use as well. It's we have a number of patients, and some of them have responded very well to treatment, but others less. So, but certainly is an option that we have to consider when is needed, and when DBS is not an option. So I think that I don't have any other questions. And yeah.
Sorry, go ahead.
Oh, there is another one here. Have you seen success using ultrasound? Now, yes, the focus ultrasound is mostly for tremor, and it seems to control the tremor, yes, but not the other symptoms of Parkinson, because it's not used for that. So if we have a patient that have a significant tremor, but with minor other slowness of movement or rigidity, then we consider ultrasound, even though, of course, at the end of the day, it would be probably ideal, better to have deep brain stimulation, because the other symptoms over time tend to get worse. So to have a deep brain stimulation would be an option to control also the other symptoms, rather than just tremor, which is used for normally used for focused ultrasound. Yes.
Thank you, Dr. Strafella. I had a couple questions. Do you have time just to ask answer a couple questions?
Okay. Yes.
I was just wondering, with abnormal behaviors such as impulse behaviors or punding, where the behaviors are repetitive, is the patient aware that the behavior is abnormal? And
yes,
how should a family member adjust to that or manage that?
Yeah, they are aware, and they're very much aware of those behaviors. And the problem is that sometimes they do not like to disclose those behaviors. And one of the reasons, and most of the time, is our family members that disclose that behavior. The reason why, because of course, when these things happen, we need to make adjustment in medication. And again, as I mentioned before, every time we may have to reduce the amount of medication, the patient is very much afraid that they get frozen, stuck, rigidity, slowness of movement, which they don't, of course, understandably, do not like. And of course, some of them, they prefer just to gamble rather than be unable to move. So it is a very difficult situation to deal with sometimes, and that's why we always involve our psychiatrists that sometimes deal with these things also in other diseases, not just Parkinson's disease. And so we ask for their help to see how we can address this problem.
Okay, thank you. And just one question about the smiling. I know you commented on apathy and depression, low mood affecting possibly why someone might not smile. Does it also have anything to do with slowness of movement, like anything physicality or
yeah, of course. Remember, all the patients have what we call these mask features, right? Like this poker face. And so that can be also one of the reasons why there is less smiling. Yes, that's can be just a motor aspect, right? But can be also behavioral aspect. So, and sometimes the two things combine, so it can be even worse. So definitely there is a motor and a behavioral component. Yeah.
Well, thank you very much, Dr. Strafella, for such an informative and interesting presentation. And thank you for answering all of our questions. Thank you all for asking the questions and for attending. Please do fill out our evaluation form that should pop up in a window. Your feedback is important to us. That should pop up in a window soon. So thank you so much again.
Thank you for joining, and it was a pleasure, of course. So hopefully it was useful for all of you. Thank you.
Thank you so much. Bye-bye.
Bye.